Hello everyone, I am Dr. Sarita Jain. In today's video, I will be discussing about the prevention and management of preterm labor. In this video, I will be covering risk factor for the preterm delivery, strategies to prevent preterm delivery, cervical length screening, evaluation of patients in preterm labor and management of preterm labor. So when will we call preterm delivery? When a baby is born before 37 week of the pregnancy, then it is called preterm delivery. This is the main reason for newborn health problem and hospital stays during pregnancy. Doctors diagnose preterm labor when a woman has regular contraction and her cervix begins to open. However, less than 10% of women diagnosed with preterm labor will actually give birth within 7 days. Preterm delivery can be further categorized as very early preterm when birth before 32 weeks happens, early preterm when birth is between 32 weeks and 34 weeks of pregnancy, and late preterm when birth is between 34 weeks and 37 weeks. Let's discuss about the common risk factors associated with preterm delivery. Certain maternal health conditions like hypertension, diabetes, infections of urinary tract, chorioamnionitis and periodontal disease, and autoimmune disorders like lupus. Some reproductive health condition like multiple pregnancies, previous preterm birth, short cervix or cervical incompetence, if there is history of cervical conjugation or loop electrosurgical excision, uterine abnormalities like septate uterus and biconvate uterus, some lifestyle factors like smoking, drug or alcohol abuse, inadequate prenatal care, poor nutrition, socioeconomic factors like low socioeconomic status, high level of stress, some pregnancy complications like placental abruption or placenta previa, premature rupture of membrane, multiple pregnancies, environmental factors like exposure to environmental toxins, a lack of access to clean water and sanitation, and some demographic factors like young maternal age, advanced maternal age, short pregnancy interval, that is less than 18 months between pregnancies, and low maternal pre-pregnancy BMI less than 19.8 kilogram per meter square. If these are present, they are associated with high risk for preterm delivery. Most of these risk factors can be modified, but short cervix and history of preterm delivery, these are two factors which we cannot modify. Short cervix is when cervical length is less than 25 millimeter before 28 week of the gestation, and if there is history of preterm delivery, then there will be 1.5 to 2 times higher risk for another preterm delivery. Now, what are the strategies to prevent preterm delivery? For women with a history of spontaneous preterm delivery, antenatal progesterone therapy is the most effective treatment. It is started from 16 to 24 week of the gestation and continued until 34 week of the gestation. Most common medicine used for this purpose is hydroxyprogesterone caproate injection. It is used to 50 milligram intramuscularly every week. If we cannot use injection, then vaginal progesterone can be used instead of injection. Now, for a woman with a short cervix but no history of preterm delivery, if there is cervical length 20 millimeter or less before 24 week of the gestation, then vaginal micronized progesterone 200 microgram daily can be used. It reduces the risk of spontaneous preterm delivery by 44% in women with the cervical length of 15 millimeter or less. It is important to remember that progesterone therapy is not beneficial for multiple gestation. Now, next strategy to prevent preterm delivery is cervical cerclage and pessary. In cervical cerclage, a stitch is placed around the cervix to prevent premature birth. It is useful for women with previous preterm birth and a short cervix, that is cervical length less than 25 millimeter. It reduces the risk of preterm delivery and perinatal death in high risk pregnancy. It is not recommended for multiple gestation due to an increased risk of preterm birth. A cervical pessary is non-surgical device which is placed around the cervix to prevent preterm birth. It is effective in reducing preterm birth rates in women with the short cervix. It may be a promising alternative or addition to other preventive measures. Now, why it is important to measure the cervical length? The risk of preterm delivery increases as the cervical length decreases. Cervical length should be measured transvaginally by a trained ultrasonographer. Now, how to evaluate a patient in preterm labor? First of all, diagnosis of preterm labor is important because less than 10% of the women diagnosed with preterm labor will deliver within 7 days of initial symptom. So, it's crucial to determine if the patient is truly in labor or if delivery is imminent. In the initial assessment, complete medical and obstetric history is done, including verifying the due date. Please try to avoid digital vaginal examination unless delivery seems imminent to reduce the risk of infection. Perform a sterile speculum examination to check for cervical dilatation, vaginal infections, bleeding, and ruptured membrane. Test for sexually transmitted infection and group B streptococcus is important because infections are linked to preterm delivery. Urine sample is collected for the urinary tract infection. Signs of ruptured membranes are positive nitrogen test, arborization or funding pattern on microscopy, pooling of fluid in the vaginal wall during the speculum examination. Tests like AmniSure can detect amniotic proteins with high sensitivity. Ultrasound may be used to assess amniotic fluid levels. Now, how to manage after ruptured membranes? Most women with preterm premature rupture of membrane will deliver within 1 week. Management depends on fetal status and the presence of complications like placental abruption, intrauterine infection. If fetal compromise or chorioamnionitis or significant abruptio placentae is present, then delivery is recommended. Now, what are the criteria for preterm labor? If there are regular uterine contraction with progressive cervical dilatation and cervical effacement, then it is diagnostic for preterm labor. Diagnosis is more certain if there are at least 6 contractions per hour, cervical dilatation is more than 3 cm and effacement is at least 80%, membranes are ruptured or there is vaginal bleeding. Now, management of patients with preterm labor. Corticosteroids are routinely used in the management of preterm labor. Purpose is to improve neonatal outcome by accelerating fetal lung maturity. For this, betamethasone and dexamethasone are used. Betamethasone is given 2 12 mg doses intramuscularly 24 hours apart, and dexamethasone is given 4 6 mg doses intramuscularly every 12 hours. They are administered between 24 and 34 weeks of the gestation or can be given as early as 23 weeks if delivery is likely within 7 days. Benefits of corticosteroid are they reduces neonatal morbidity and mortality, they decrease the risk of respiratory distress syndrome and intraventricular hemorrhage and necrotizing enterocolitis. A second course may be given if the first was administered more than 7 days earlier and preterm delivery is still a risk. Side effects are usually minimal, but there can be short-term maternal glucose intolerance or slightly increased risk of infection can be there. Second drug used for the management of preterm labor is magnesium sulfate. They provide neuroprotection to the infant and reduces the risk of cerebral palsy. Dose is 6 gram bolus IV over 20 minutes, then 2 gram per hour as a continuous infusion. This significantly reduces the risk of cerebral palsy in preterm infants. Side effects, maternal side effects are flushing, nausea, loss of deep tendon reflexes, respiratory depression and cardiac arrest, and fetal complication is neonatal depression. They are contraindicated in myasthenia gravis patient. They should be used cautiously along with calcium channel blockers or beta adrenergic agonist due to risk of serious maternal complications. Apart from corticosteroids and magnesium sulfate, tocolytics are also used for the management of preterm labor. Purpose is to delay delivery to allow for corticosteroid administration and maternal transport. Many medications are used for this purpose. First is nifedipine. It is a calcium channel blocker. Dose is 30 mg loading dose orally, then 10 to 20 mg every 4 to 6 hours. It is effective in delaying delivery. It has fewer side effects as compared to other tocolytic agents. Side effects are dizziness, flushing, and hypotension. It is contraindicated in patients with hypotension and certain cardiac conditions. Next tocolytic agent is indomethacin. It is a prostaglandin inhibitor. It is used in 50 to 100 mg loading dose orally or rectally, then 25 to 50 mg every 4 to 6 hours. It is used for up to 48 hours only. It can delay delivery and effective in reducing the uterine contraction. Side effects are nausea, gastritis, potential fetal issues such as ductus arteriosus constriction and oligohydramnios. And if it is used beyond 48 hours, then there is risk of premature closure of ductus arteriosus and reduced amniotic fluid levels. It is contraindicated in platelet dysfunction, renal dysfunction, gastrointestinal issues and hypersensitivity to aspirin. Next tocolytic agent is terbinafine. It is a beta adrenergic agonist and dose is 0.25 mg subcutaneously every 20 to 30 minutes for up to 4 doses or as an IV infusion starting at 2.5 to 5 microgram per minute, and doses are adjusted as per requirement. It is effective in delaying labor. Side effects are tachycardia, hypotension, tremors and pulmonary edema. It is contraindicated in tachycardia sensitive cardiac diseases, poorly controlled diabetes mellitus. Magnesium sulfate can also be used as a tocolytic agent and doses are same as used for neuroprotection, but it is generally not preferred as a primary tocolytic agent due to potential complications. Tocolytics are used to delay delivery for up to 48 hours. Continuous or long-term use does not further delay delivery or improve outcome. Try to avoid tocolytics in cases of fetal distress, chorioamnionitis or maternal instability. Antibiotics are also used for the management of preterm labor. They are used to prevent and manage intrauterine infection and provide prophylaxis for group B streptococcus. They are effective in managing specific infection but not shown to delay delivery or reduce neonatal morbidity. There are certain conditions where tocolytics should not be used. Tocolysis is not recommended if the fetus has died in utero. If the fetus has a condition that is incompatible with life, then tocolytics are contraindicated. Persistent abnormal fetal heart rate pattern or other signs of fetal distress are also contraindicate the use of tocolytic. Tocolytic is not suitable if the mother has severe preeclampsia or eclampsia due to the high risk of complications. Active maternal bleeding with signs of instability precludes the use of tocolytics. Active infection of the amniotic sac and membranes contraindicate tocolysis due to the risk of worsening infection. While tocolytics may be considered in PPROM without maternal infection for purpose like transport or steroid administration, their use is generally avoided if there is evidence of infection or other complications. Certain tocolytic agents have additional contraindication based on individual patient factors such as cardiac diseases for the beta adrenergic agonist or renal dysfunction for prostaglandin inhibitors. Tocolytics should be avoided in these situations to prevent potential harm to both mother and fetus. So this was all about the prevention and management of preterm labor. If you found this video useful, please like and share the video and subscribe my channel. Thank you.